Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues, we know WHO has declared global red alert about monkeypox, and it becomes our responsibility to know the known facts about monkey virus. Unfortunately, within 2 to 3 months, Spain, it is spread to more than 75 countries around the world. And cases have been reported from our neighbor country, India, as well. Alhamdulillah, no case has been found in Pakistan yet, but it doesn't mean that we should remain ignorant. We need to be vigilant, and we need to be having low threshold for detecting such cases. So in today's lecture, I would like to share with you the known facts about monkeypox virus, and let's hope that Pakistan is spared from it. But God forbidden, if it comes, we should be knowing what's our role and how we should go about. So my aim of today's discussion is that regarding monkeypox, should we be worried? This is the question of today's. As I said, the WHO has declared highest alert over the outbreak. This is a recent one because more than 16,000 cases have now been reported from 75 countries. Fortunately, only 5 deaths have occurred so far, and it is far much less as we saw in COVID. But point is that within 2 to 3 months, as this recent outbreak started from UK on 7th May, so within these 2 to 3 months, it has cases have been reported from more than 75 countries. So this is really alarming. On 27th July, this is the CNN report that Asia on high alert for monkey as cases were reported from India to Japan. The passengers which reached Japan, and when they were tested, they were positive for the monkeypox. So it means our neighbor countries has become prey of this monkeypox virus. On 30th May, the government of Pakistan has declared high alert against monkeypox. But Alhamdulillah, till now, no case has been confirmed in Pakistan. 20 to 25 cases they were suspected, but none of them was diagnosed to be having monkeypox. That's a good point. What's monkeypox? We all know monkeypox is an enveloped double-stranded DNA virus that belongs to the Orthopoxvirus genus of the Poxviridae family. And this is the same group to which the smallpox virus belongs. There are 2 distinct genetic clades of monkeypox virus. One is the Central African or Congo Basin clade, and another is the West African clade. The Central African or Congo Basin clade, this is the notorious one, this is the severe one, and up to 11% mortality rate has been reported with this. As compared to this is the West African clade, 1 or less than 1% mortality rate has been reported with this, and the recent outbreak is considered to be because of this. The geographical division between the 2 clades has been reported from the Cameroon. Cameroon is the country where both the clades are present, while then when you go out of the Cameroon to the one side, the Congo Basin clade is there, and to the other side, the West African clade is there. But the Cameroon country, you see both these clades to be present. We can divide the clinical features into 3 phases: the incubation period, then the phase with characterized by the fever, the lymphadenopathy, and then the skin rash and the vesicular. The incubation period in this case, it's we know it's the interval from infection to the onset of the symptoms. It ranges from 6 to 13 days, but it can range from 5 to 21 days. So the incubation period is maximum to 3 weeks. The clinical phase starts with the fever with lymphadenopathy, and it lasts from 1 to 5 days. There is a headache, there's fever, there is a lymphadenopathy. The patient becomes exhausted. Patient has got the backache, the muscle cramps. The lymphadenopathy is a distinctive feature of monkeypox as compared to the other diseases that may initially appear similar, like chickenpox, measles, and smallpox. In those, the cervical lymphadenopathy is not there, while in monkeypox, it is the feature. The third phase is that of the skin rash and vesicular lesions, and they begins within 1 to 3 days of the appearance of the fever. The rash tends to be more concentrated on the face and extremities rather than on the trunk, like in these patients. In 95, the face is involved in 95% of the cases. The palms and soles, they are involved in 75% of the cases. This is again the same in 75% of the cases, oral mucosa in 70% of the cases, genitalia in 30% of the cases, and conjunctiva and cornea may be involved in 20% of the cases. So this is the patient the trunk may be involved, but as we saw, the face is the maximum vesicles we see on the face, then the palms and soles, then oral mucosa. Again, you see here they are present, but they are scars not as common as they were on the face. We all know the rash involves sequentially from macules, which are the lesions with a flat base, to papules, which are slightly raised from lesions, then vesicles, and then pustules. The number of lesions they varies from few to several thousand even. So, and in any patient, you may see a couple of phases. I mean, you may see few macules, then papules, then vesicles, and then pustules. In severe cases, lesions can coalesce until a large sections of the skin sloughs off. So cases have been reported on that as well. A good point is that the monkeypox virus usually causes mild illness in patients. Symptoms can appear between 5 to 21 days after infection, and the virus can last for 2 to 4 weeks. Complications of monkeypox can include, in severe cases, in immunocompromised cases, and these include secondary infections, bronchopneumonias, sepsis, encephalitis, infection of the cornea, with ensuring loss of the vision. So, in severe cases, the dreadful complications may be there. How does it spread? We know this is a zoonotic disease, and it is acquired from the animals. We all know zoonotic diseases are whether the animals get infected from the human or the humans get infected from the animals. Animals to human transmission can occur from direct contact with blood, like slaughtering, all those things, body fluids or cutaneous or mucosal lesions of the infected animals. In Africa, evidence of monkeypox virus infection has been found in many animals, including rope squirrels, tree squirrels, Gambian pouched rats, dormice, different species of monkeys, and others. And the natural reservoir of monkeypox has not yet been identified, though rodents are the most likely. Eating inadequately cooked meat and other animal products of infected animals is a possible risk factor. People living in or near the forested areas may have indirect or low level exposure to infected animals. Human to human transmission can result from close contact with respiratory secretions. Skin lesions of an infected person are recently contaminated objects. Transmissions via droplet respiratory particles usually requires prolonged face-to-face contact. I repeat, prolonged face-to-face contact, which puts health workers, household members, and other close contacts of active cases at greater risk. However, the longest documented chain of transmission in a community has risen in recent years from 6 to 9 successive person to person infections. This may reflect declining immunity in all communities due to cessation of smallpox vaccination. In 1968 or 70, the smallpox vaccination has been stopped. So maybe that after 40 years, the efficacy is going down. And it is exposing, probably they were also protecting against the monkeypox. Transmission can also occur by the placenta from mother to fetus, which can lead to congenital monkeypox and during close contact during and after birth. While close physical contact is a well-known risk factor for transmission, it is unclear at this time if monkeypox can be transmitted specifically through sexual transmission routes. Studies are needed to better understand this risk. The WHO says that the natural reservoir of monkeypox has not yet been identified, but the various virus mostly transmits from rodents to primates. And as I said before, the rope squirrels, tree squirrels, Gambian pouched rats, dermice, and all these are the possible natural reservoirs. I already said, just to rephrase or summarize, that close physical contact is one of the way of it spreading, then contaminated materials of a patient, and of course the respiratory droplets. But remember, prolonged face-to-face contact is required in this case. Where is monkeypox found? The monkeypox primarily originates in the tropical rainforests of Central and West African countries, and it is mainly spread through wild animals. Uh, the infection, where was the first case of monkeypox? The infection was first discovered in 1958 after a pox-like disease outbreak occurred in monkeys used for research in the Denmark. And that's the reason this virus has got the name of monkeypox. It's not basically residing there in the monkeypox. The monkeys were secondarily infected in 1958, and that's the reason its name has acquired from this. And as said here, we saw that the face is the mostly affected part of the body. The same is here. Where was the first case of monkeypox in humans? The first human case of monkeypox was recorded in the Denmark Republic of Congo in 1970 in a 9-month-old baby. So it was in 1970 when the first case of human was recorded. And since then, the outbreaks are happening inside Africa and outside Africa. Inside Africa, since 1970, human cases of monkeypox have been reported in 11 African countries: Benin, Cameroon, and Republic, the Congo, and so many, Nigeria. And outside Africa, in 2003, the first monkeypox outbreak was outside Africa was in the USA, where 250 cases they were confirmed, and the reason was that the dogs and animals they were transported from Africa to here, and they caused this disease. In 2018, in Israel and UK, the outbreak happened, and in 2019 in Singapore, another outbreak happened. The recent outbreak, the first case was confirmed in England on May 7, and since then the new cases are being emerging, and all the different countries, the Sweden, UK, Belgium, Portugal, Germany, Italy, Spain, all these are being Australia, all cases have been reported there. And as I said in the start, more than 75 countries and more than 16,000 cases have been reported so far. How is monkeypox diagnosed? The clinical differential diagnosis that must be considered includes other rash illnesses like chickenpox, measles, bacterial skin infection, scabies, syphilis, and medication-associated allergies. As I said before, lymphadenopathy during the prodromal stage of the illness can be a clinical feature to distinguish monkeypox from chickenpox or smallpox. If smallpox is suspected, health workers should collect an appropriate sample from the lesion and have it transported safely to the laboratory with appropriate capabilities. This is very, very important. Confirmation of monkeypox depends on the type and quality of the specimen, of course, and the type of laboratory test. Thus, specimen should be packed and shipped in accordance with the national and international criteria. As I said before, orthopoxviruses are serologically cross-reactive. Therefore, antigen and antibody detection methods do not provide monkeypox-specific confirmation. Serology and antigen detection methods are therefore not recommended. So they are not recommended for diagnosis of case investigation where resources are limited. So don't go for that. Antigen antibody detection methods may not be useful in such cases then. So what's the answer? This is the polymerase chain reaction, which is the preferred laboratory test given its accuracy and sensitivity. For this, optimal diagnostic samples for monkeypox are from the skin lesions, roof or fluid from the vesicles and pustules and dry crusts. Where feasible, biopsy is an option. Lesion samples must be stored in a dry, sterile tube, no viral transport media, and kept cold. PCR blood tests are usually inconclusive because of the short duration of the viremia. So the PCR should be done on the samples from the lesion. Is there any treatment? Currently, there is no specific treatment for monkeypox. It's a self-limited disease with symptoms lasting from 2 to 4 weeks. Most people with monkeypox get better on their own without treatment. General measures are required, asymptomatic treatment is required, good radiation is required. Vaccines and antiviral drugs developed to fight smallpox. People are thinking that they may be effective here as well. But the important point is the COVID-19 preventive methods must be adopted if cases confirmed, the contact tracing, the testing of that contact, and of course the quarantine when the patient is become found to be positive. Clinical care for monkeypox should be fully optimized to alleviate symptoms, manage complications, and prevent long-term sequelae. Patients should be offered fluids and food to maintain adequate nutritional status. Secondary bacterial infections should be treated as indicated. An antiviral agent known as tocilizumab that was developed for smallpox was licensed by the EMA, European Medicines Agency for monkeypox in 2022. Based on the data in animal and human studies, it is not yet widely available. And if it's used for patient care, tocilizumab should be ideally be monitored in a clinical research context with prospective data collection. This is that drug with the name of TPOX, 200 milligram capsules. The dose is from 40 to 120 kg. Then it's given 3 capsules BD for 2 weeks. And if it's more than 120 kg body weight, then 3 capsules 3 times a day for 14 days. And within 30 minutes after eating a full meal. And if oral is not possible, then injectable can be given. But remember, this is the research tool till now. Yes, on the 3rd August, the CDC statement is that the guidance for tocilizumab use under expanded access investigational new drug protocol during 2022 US monkeypox cases, and they've got a very strict criteria, and they want the informed consent of the patient. So maybe in the coming months we get the data from this, but till now, if at all it is, and they have limited its use in very critical cases. So what about the vaccination? Vaccination against smallpox was demonstrated through several observational studies to be about 85% effective in preventing monkeypox because they both belong to the same group. Thus, prior smallpox vaccination may result in milder illnesses. Evidence of prior vaccination against smallpox can usually be found as a scar on the upper arm. And those of my age, we had the smallpox vaccination. At the present time, the original first generation smallpox vaccines are no longer available to the general public. Some laboratory personnel or health workers may have received a more recent smallpox vaccine, maybe to protect them in event of the exposure to orthopoxviruses in the workplace. Still, a newer vaccine based on modified attenuated vaccinia virus, which is the Ankara strain, was approved for the prevention of monkeypox in 2019. This is a two-dose vaccine for which availability remains limited. Smallpox and monkeypox vaccines are developed in formulations based on the vaccinia virus due to cross protection afforded for the immune response to orthopox viruses. How we can prevent from it? Raising awareness of risk factors and educating people about the measures they can take to reduce exposure to the virus is the main prevention strategy for monkeypox. So please do educate people around you. Scientific studies are now underway to assess the feasibility and appropriateness of vaccination for prevention and control of monkeypox. Maybe in the coming months or a year or so, the vaccine is offered for protection. Some countries are developing policies to offer vaccines to persons who may be at risk, such as laboratory personnel, rapid response teams, and healthcare workers. What about the monkeypox and chickenpox? Although they both cause skin rashes, monkeypox and chickenpox are caused by different viruses. We know that. Monkeypox is an orthopoxvirus, while the chickenpox is herpes virus. Both viruses can be spread through skin to skin or prolonged face to face contact. But chickenpox is very contagious and spreads more easily than monkeypox. People with monkeypox are more likely to have swollen lymph nodes than people with chickenpox, and the rashes act differently too. While the chickenpox rash can appear in waves, monkeypox sores develop at the same time. Chickenpox symptoms, including the rash, tend to get better within 2 weeks, while it takes 2 to 4 weeks for monkeypox to resolve. So these are the difference between these two. What about the monkeypox and smallpox? The smallpox and monkeypox are both part of the orthopox family. We know that. So they are caused by, by similar but distinct viruses. Thanks to the effective vaccine, smallpox was eradicated. It's no longer circulating disease by 1980. The smallpox was very, very contagious and spread more easily than monkeypox. Monkeypox symptoms are similar but milder than smallpox symptoms. How monkeypox relates to smallpox? This is another question. Smallpox was easily transmitted and more often fatal, as about 30% of patients died. Here, as I said, in one strain, the Basin strain, 11% mortality, and the West African, it's less than 1%. And in that, it was 11%. The last case of naturally occurring smallpox occurred in 1977, and in 1980, smallpox was declared to have been eradicated worldwide after a global campaign for vaccination and containment. It has been 40 or more years since all countries ceased routine smallpox vaccination with vaccinia-based vaccines. As vaccination also protected against monkeypox in West and Central Africa, unvaccinated population are now also more susceptible to monkeypox virus vaccines. So this is one correlation between these two. Whereas smallpox no longer occurs naturally, the global health sector remains vigilant in the event it could reappear through natural mechanisms, laboratory accident, or deliberate release. So countries, they are at alert even for the smallpox as well. To ensure global preparedness in the event of reemergence of smallpox, newer vaccines, diagnostics, and antiviral agents are being developed. Still, work is going on that as well. These may also now prove useful for prevention and control of monkeypox. So this is the way the monkeypox is related to the smallpox. So, my dear colleagues, as I said before, the WHO has declared highest alert about the monkeypox, and Now, this is our responsibility as a healthcare worker to be vigilant and to have our threshold of suspecting monkeypox low. We should educate people around us, and if there's any suspected case, we should go for the early confirmation detection. Thanks to Allah that the no case has been confirmed from Pakistan yet. But as I said before, in our neighbor country, the India cases have been reported from. So we should be very vigilant. We should be very careful, and we should be keeping ourselves updated for the latest knowledge and latest news about the monkeypox virus. I pray our country remains safe and free of this monkeypox. I mean, so I hope that in today's discussion on the monkeypox, I was able to share with you the basic concepts and the facts known so far regarding the monkeypox. And as the other data will come, we may discuss this at length in our future discussions. Thank you very much. Take care of yourselves and your family. Khudafez and goodbye.